I'm Nigel Deeks, a CML patient since 2011. I'm here today representing the CML Advocates Network.
My name is Daniela Žáčková and I am hematologist-oncologist at the University Hospital Brno in the Czech Republic.
What is CML?
CML, or chronic myeloid leukemia, is a malignant disease or simply cancer of the blood. Chronic means that it develops quite slowly, typically taking months or years to progress. Myeloid is the name of the group of cells affected, and the word leukemia means white blood, the finding caused by the presence of large amount of white blood cells in the blood. In CML, there have been remarkable advances in treatment for last 2 decades, and the prospects are very good now for people living with the disease. Their prognosis is really excellent, with almost normal life expectancy and very good quality of life.
Can you tell me why I got CML? And did I bring this onto myself through any lifestyle choices?
We know that CML originates from genetic mistake, which is not inherited from your parents. It is something what happened during your life. We call it sort of acquired genetic change. We, however, still do not know what the reason for this genetic change is. Impact of anyone's lifestyle was not approved. The only clearly recognized risk factor is exposure to very high doses of ionizing radiation. So actually, for most people who have CML, there are no obvious reason why they develop the disease. CML may affect everyone at every age, but it is much more common in older people. The average age on the onset is in the 60s. CML is a rare disease. Approximately 1 to 2 people develop the disease in every 100,000 people per year.
When I was diagnosed with leukemia, I didn't really understand how I could have a blood cancer because most cancers are solid. Can you help me with some information on that?
Blood is formed by cells and fluid part, which we call plasma. There are 3 main types of blood cells. Red blood cells that contain hemoglobin, which carries oxygen to all of the tissues of the body, platelets that are responsible for initiation of clotting if you would cut yourself, and white blood cells that, among other functions, defend the body against the infection. All these 3 types of blood cells are produced in bone marrow. And all these cells I mentioned originates from one single cell, which we call hematopoietic stem cell. And this stem cell gives rise to all of these blood cells. The acquired genetic change in CML takes place in the stem cell in the bone marrow, and it is passed to all new white blood cells originating from it. And in this particular genetic change, 2 genes that are normally unrelated are attached each to other and formed new fusion gene, which is abnormal, pathological, and strong enough to induce CML.
I've heard mention of the Philadelphia chromosome and chromosomal translocations. What exactly are these?
The abnormal fusion gene, as I have just described, is a result of such a translocation. Normally in healthy people, every cell contains 23 pairs of chromosomes. In CML, small parts of chromosomes 9 and 22 are broken off and exchanged mutually. As a result of this translocation, chromosome 22 ends up as shortened version of itself, and this was for the first time described at the University of Pennsylvania in Philadelphia in 1960. That's why it was named Philadelphia chromosome. Due to its translocation, gene which is named ABL is attached to a gene called BCR, and this newly formed fusion gene BCR-ABL is a trigger of CML.
Is there any risk of passing my CML onto any other person?
No, the BCR-ABL fusion gene cannot be passed onto anyone else. This abnormality is present just in bone marrow and blood cells, neither in reproductive nor any other cells in the body. It is acquired genetic change, not inherited. It is also impossible to catch CML from anyone else, as it is not infectious at all.
How does this genetic change affect my CML?
The abnormal fusion gene BCR-ABL gives rise to a protein which is also abnormal, and it is called BCR-ABL tyrosine kinase. This protein gives the bone marrow cells instructions to keep overly dividing. You can imagine it like that it is stuck in the position on without any possibility to be switched off. This pathological activity results in an uncontrolled overproduction of white blood cells that accumulate in bone marrow, spill out into the blood, and can clog the spleen and the liver. In addition, these pathological white blood cells live longer than the healthy ones.
So that would explain when I was diagnosed why my white count was so high.
Definitely, yes.
Personally, I didn't feel ill at diagnosis, although I had noticed I'd been losing weight and suffering with night sweats. Are there many other symptoms that are common with a diagnosis of CML?
Common signs and symptoms of CML result from an increased basal metabolism due an unneeded overproduction of white blood cells. They can include, as you mentioned, night sweats, fatigue, fevers, loss of appetite, unexplained weight loss. Quite often spleen enlarges, and less frequently so does the liver, and this can cause a sensation of feeling full when eating. Sometimes it is even felt as a stomachache. When the white blood cell count is very high, it can cause a sort of leukostatic symptoms, which are, for example, blurred vision, headache, shortness of breath, or priapism. Overproduction of white blood cells can lead also to decrease of other cells produced by bone marrow. Decrease of red blood cells may lead to anemia with shortness of breath, dizziness, tiredness, and pale appearance as main symptoms. Lack of platelets may lead to bleeding or ease of bruising. Sometimes people can experience joint and or bone pain. Most of the symptoms I have mentioned are not specific for CML, as they are associated with many other diseases. But what is quite specific for CML, that of about half of people, or 50% of people, are completely asymptomatic at the time of diagnosis. So many of them are only diagnosed following blood tests conducted for other reasons.
Can you tell me how CML progresses?
Actually, there are 3 phases of CML: chronic phase or early phase, accelerated phase, and blast phase or blast crisis. Sometimes we put together accelerated phase and blast phases and call them sort of advanced phase of the disease. It's important to note that a vast majority of patients, of about 95%, are in the chronic phase at the diagnosis. For chronic phase, it's characteristic that accumulating white blood cells are also keep maturing, so they are still able to do their jobs. It means that symptoms are usually mild, if any. What is typical is that patients diagnosed in chronic phase usually respond very well to modern therapy, and that their prognosis is really excellent, with normal lifespan and very good quality of life. Minority of patients are diagnosed in so-called advanced phase. It is also quite rare for people who were diagnosed in chronic phase to progress to either directly to the blast phase or through the accelerated phase.
What would happen if the disease were to progress?
During the progression, proportion of very immature cells, blasts, increases, and they are so immature that they are not able to function or to do their job. So infections, fevers are more common at advanced phases of the disease. We call such cells as blasts. Blasts are rapidly dividing and accumulating in bone marrow, so they can crowd out other cells. And as the overproduction of blasts is really very high, also the non-specific symptoms of CML, such as fatigue or weight loss or night sweats, can be present and much more profound than it is expected in chronic phase of the disease. We can say that blast crisis resembles acute leukemia. It definitely should be treated more intensively, and unfortunately also prognosis of patients diagnosed or progressed into blast crisis is completely different to the chronic phase.
Does the disease progress to an advanced phase in all CML patients?
Fortunately not. And this is one of the most important achievements of the modern therapy. Nowadays, most of the patients can remain in chronic phase for the rest of their lives without having their disease progressing to advanced phases.
How is CML actually diagnosed?
Patients with newly diagnosed CML are very often without any symptoms, or their symptoms are quite unspecific and mild. And suspicion on CML is based on characteristic changes in full blood count and differential, which is the name for quite detailed investigation of particular types of white blood cells. When we look at the full blood count of patients with newly diagnosed CML, we can see very often quite highly elevated white blood cell count. We also can see changes of numbers of other cells. Platelets can be increased or decreased, and looking at hemoglobin level tells us if the patient is or is not anemic. Even though CML is highly suspected from these blood count findings, for accurate diagnosis is necessary to confirm the presence of Philadelphia chromosome or BCR-ABL gene.
When I was diagnosed, I had a bone marrow sample taken. Is this still necessary?
As I mentioned, for accurate diagnosis we need confirmation of presence of Philadelphia chromosome or BCR-ABL gene. The bone marrow is the only way how to look at chromosomes. The investigation, which is called cytogenetics analysis, is sort of outpatient procedure. It takes 10 to 15 minutes when the bone marrow sample is taken by a special needle. However, in about 5% of patients with CML, Philadelphia chromosome cannot be detected by this cytogenetics analysis, as it is somewhat hidden. We can divide also patients diagnosed in chronic phase into 2 or 3 risk categories according to scoring systems, for example, Sokal, Hasford, etc., and then use quite simple entry characteristics such as age, spleen size, number of platelets, percentage of blasts, and other types of leukocytes to calculate entry score. And it is important as people classifying as high risk score should be treated more intensively from the beginning to achieve the excellent outcome.
How is response to treatment measured?
Actually, there are 3 levels of responses. At first, we look at the blood count if everything is normalized during the treatment. Patients should start feel well again, and spleen should be normal as before the diagnosis, and this state is known as complete hematologic response. It should be achieved until 3 months after the start of the therapy. The next level of response is cytogenetic response. The situation when there are no Philadelphia chromosome positive cells in the bone marrow is known as complete cytogenetic response, or CCYR for short. And this is very important achievement, as we already know that patients who achieve complete cytogenetic response have good prognosis. And the third level of response is what we called molecular response. And this is response which can be measured by quantitative PCR. The monitoring of response to therapy is absolutely crucial part of management of CML patients.
I've heard of qualitative and quantitative PCR testing. Can you explain the difference to me, please?
The PCR, or polymerase chain reaction, is a very sensitive method of molecular analysis. Thanks to this method, we can look at the form of genes which we call transcripts, which is more feasible to evaluate and to investigate. So we call about BCR-able transcripts. And when we use qualitative PCR, we just detect the gene or transcript, so we can confirm diagnosis of CML. It's very important, and we also we also find out what the type of the BCR-able transcript is. It is very important because after that we can follow the patient, we can monitor response to the therapy thanks to quantitative PCR, when we can measure the amount of BCR-able transcript. So qualitative is for detection, for diagnosis confirmation that it is present, and quantitative is for measuring amount, is for monitoring of the statement of the disease and for response to the therapy. What is very important to say, and it is advantage mainly for patients, that PCR tests can be done just from the peripheral blood. The bone marrow analysis is not necessary in terms of PCR testing.
In my own mind, I often think of my PCR results falling by way of a lawn, which is an odd analogy, I know, but one that I think works very clearly. For example, if you imagine that when you're first diagnosed, you have a wilderness of grown grass. It's cut back for one log, so it's relatively short. The second log makes it even shorter, and the third log brings it down to very, very trimmed grass. TKIs don't actually kill the roots. The roots, in CML terms, being stem cells, but what they do is to continually mow this grass, for lack of a better analogy. Therefore, if you were to stop taking your drug, then this grass could start growing, or in layman's terms, your CML would undoubtedly get worse. Would that be a fair sort of comparison, would you say?
Yes, it's absolutely fair comparison, and it is proven that TKIs definitely cannot affect stem cells.
I'm interested to know what treatment options are available to CML patients.
Well, treatment for CML patients has changed profoundly since the introduction of targeted drugs called tyrosine kinase inhibitors into clinical practice in 2001. These revolutionary drugs are taken as tablets orally by mouth once or twice daily, and they target directly by BCR-ABL tyrosine kinase. They slowly destroy leukemic cells by targeting this protein. Nowadays we have 5 slightly different tyrosine kinase inhibitors available. 3 of them for first-line therapy, which means for newly diagnosed patients as an initial therapy, and for situations when the first-line therapy doesn't work properly or is not tolerated. It means that the drugs cause some side effects. We have second-line treatment.
How long does TKI treatment last?
I have to say that the treatment of CML is different to almost all other cancers from this point of view. Most of the people with CML should remain on their therapies for whole life. Even though they doing well, they are without any symptoms, and even their response is very deep. We unfortunately can't say that they are cured, so we have to keep the disease under control with the medication.
Are there any other treatment options other than TKIs?
Yes, there are. I would like to mention interferon alpha. We still do not know how the drug exactly works, but we know that it influences immune system. What is important in the TKI era is that only interferon is the safe drug during pregnancy. As for other treatment options, I have to mention allogeneic stem cell transplantation. It is sort of moved into not second, third, fourth line of therapy when 2 or more TKIs do not work properly, and it is still a very valuable treatment option for advanced phases of disease. To treat and to cure people from blast crisis is possible only with allogeneic stem cell transplantation.